Introduce to you Professor Dr. Ralph Kissling from Germany. Dr. Kissling has been trained in Mainz, Germany. He has finished the medical school there and his postgraduate thesis at the same university. He had his postgraduate training in Boston, USA, and is actively teaching. He's working in an academic hospital there. The hospital is called St. Maria Krankenhaus. In English, I think it's called St. Mary's Hospital, right?
Correct, yes.
Okay, my German is not so good. Professor Kissling's main interests are in advances in endoscopic imaging, inflammatory bowel diseases, molecular imaging, teaching and simulation in endoscopy, and gastroesophageal reflux disease. He has several publications and a lot of, as I said before, teaching activities regarding these matters. So we have asked him to come here and talk and give us a lecture about the advances in endoscopic imaging, colonoscopy and imaging, endoscopy in general. So it is a great honor and a privilege, as I said before, to welcome you in Athens, Dr. Kissling, and we're looking forward to your lecture. Thank you very much for coming.
Yes, thank you very much for these kind words and your kind invitation. My Greece is not so well, so I hope I'm allowed to speak English. And I would like to focus today about new possibilities, mainly in colonoscopy. And first of all, I have very good news. So if you would go to colonoscopy, you know that your mortality is decreased. We were unsure about this issue because we knew that if we would resect polyps, there might be a protection, but there's one publication which is so essential, which was published 2012 in the New England Journal of Medicine, showing that the mortality of the patient is reduced about 53%. However, if you would have colonoscopy, you would say, I'd like to have 100% reduction in mortality. Moreover, there are very recent publications in the New England Journal showing that the best thing what can happen to you personally is that you have a normal colonoscopy. Second is you have a normal sigmoidoscopy, but even if you have polyps, your risk is not reduced to 0%, but it's better than not doing a colonoscopy. Furthermore, if you think on the anatomy in the colon, proximal cancers cannot be as good detected with colonoscopy as we thought in the past. So even if you do complete colonoscopy, you might overlook cancers on the right side of the colon. And there's a true nightmare for endoscopists. You know what is the nightmare? If you tell a patient, yes, I resected some adenomas, please come back in 3 years. Or you would say to the patient, everything is fine, I didn't see anything, please come back in 10 years. If such a patient would develop cancer in that period, this is called the interval cancer. And the Polish group with Professor Regula, they have published in the New England Journal of Medicine that this can happen. They have a screening program very similar to Germany, and they screened more than 40,000 persons with colonoscopy. 42 interval cancer occurred. Very interesting, there are 2 risk factors. With one risk factor, we cannot do anything, which is the age of the patient. But the second is the adenoma detection rate. And please have a look here. If you would do colonoscopy yourself and your personal adenoma detection rate is 20%, meaning that in every 5th patient you find at least one adenoma, then the risk for your whole population, what you're screening, is almost 0 to develop colon cancer. However, if your adenoma detection rate is decreased, maybe between 15%, 11, or below 11%, then you see that the problem occurs. Then at last year, Digestive Disease Week, this was calculated again. And most interestingly, that adenoma detection rate is really a quality marker for colonoscopy, and it was shown that your adenoma detection rate should be above 30% to exclude interval cancers. I can tell you from the German perspective, we have that nationwide screening program. The adenoma detection rate of all gastroenterologists in Germany is 19%. So we are not in that range of above 30%. There are 2 new publications showing what is the real value or number of interval cancers, there are 9 studies pooled, and you see that 58 of 1,000 patients developed interval cancers. This is quite high. Luckily or sadly, only or almost 9 patients died because of colon cancer. So what can we do? There are new colorectal cancers, they are not changeable. You know, these depressed colorectal cancers or very fast-growing cancers, this will always happen, but this is only between 14 to 24% of all cases. Then we have missed lesions, and that will be the main topic of my talk. How can we improve our adenoma detection rate? And then we have to improve our adenoma resection techniques, that everything is really removed. And additional categories means that we have to stick to accepted quality guidelines like withdrawal more than 6 minutes and to do a proper colon preparation for the patients. So what could be the first thing we can do? That would be looking behind folds, and maybe you know Douglas Rex, one of the famous colonoscopists in the United States, and he's really a skilled colonoscopist. He did a very nice study, and he said in 1,000 patients, he would do retroflex on the right side of the colon because, as we know, there are more serrated lesions which might harbor a higher risk to develop cancer. And I'd like to show you a short video clip because that we did not in the past because we thought retroflex would lead to perforation. But then if you go very in retroflex position and very slowly back on the right side of the colon, then you have a very nice view behind the folds, and then you can identify those small polyps in the right side of the colon which might harbor serrated components which can trigger the development of colon cancer easier than pure adenomas. And even his skilled hands, he had a miss rate of 10% of adenomas, which could be identified additionally. And on a per patient analysis, almost 5% of his patients had newly diagnosed adenomas or serrated lesions on the right side of the colon. And that triggered the development of new devices. And maybe you know about the third eye retroscope. And this is a very simple endoscope. However, it can be passed over the working channel of a normal endoscope. And then with a fiber optic view, you can see your mother endoscope, but also you can see behind the folds. It's not something if you get dizziness because one endoscope view is going in that direction and the other in the opposite side. And as you can see, you cannot clean that little endoscope, so you have to really target with the water to clean this little endoscope. It's not practical at all, but it shows if you do so that you can identify more adenomas. If you would do 2 colonoscopies, one after the other, your miss rate is about 20%, but here 23% could be seen in addition by using that third eye retroscope. So then the further development was to develop other endoscopes which can have a wide view endoscopy. But just to summarize the first section, its colonoscopy is still standard, but it's not as perfect as we thought in the past, and we have to have a dedicated look on interval cancers. So the development is about new colonoscopes. As you know, the standard endoscopes, we just look into the lumen, but the polyps are on the periphery. So it would be interesting to have a colonoscope with 3 optics or a panoramic view with 300 degrees. And that became possible. It's very recently published, the first study, and also the system is available. You can see it also here on your conference. And there is the distal part of the endoscope. And now you have LED light, and you have 3 optics. One is going in the center as normally, and then one to the right and to the left. I was able to use that instrument in my clinic, and I'd like to show you how colonoscopy is done with that technique. And most interestingly, navigation is so easy. You know, sometimes it takes you time to the cecum, and sometimes you do not know whether you have to go to the right or to the left. So that is your normal view in the middle, and then these are the additional panoramic views, like driving a car, and you can look to the right and to the left into the window. Now go to the left flexure, and you see that's the normal view in the middle, but on the right and to the left you can see in between the folds, which is most important to identify polyps. Now the mid view is blocked. You do not know whether to go to the right or to the left. It's to the right, so you navigate to the right. Now it moves a little bit to the left, and it's easy to pass this flexure. Now we have a look, very nice, to the ileocecal valve here and the appendix orifice during the same session. So again, you can navigate quite nicely and easily into the terminal ileum. You need a little bit of pressure. Again, you can't see nothing here because the valve is closed, but then you pass into the ileocecal valve quite easily. So the time to the cecum is shortened by using that instrument. However, the withdrawal time might be a little bit longer because you have to concentrate on additional screens, and here on the left screen you can now see the polyp, which is then centered by turning the endoscope, and you can target with your biopsy forceps. So this is now the study which was presented at the plenary session at DDW as well as UEGW. So if you start with a fused colonoscope, how is it called? If you do a second colonoscopy right afterwards, you see your miss rate is about 7.6%. But if you do standard colonoscopy first, what we're doing all the time with one optic, and then you use the 3 optics, then you have missed 41% adenomas. So this is, I think, disruptive technology where you can identify much easier adenomas or polyps, and that will bring us above this threshold of 20%. An alternative technique is now this new GI colonoscope where you have a balloon at the distal end, and this balloon is insufflated during withdrawal all the time. And then the folds are expanded, and you can see much better between the folds because the air is trapped between the balloon and the cecum, and then also polyp detection becomes much easier than it was in the past. And this was presented also at last year UEGW, and you see the same study as we have had for the fused colonoscope. And again, by using this kind of technique, your miss rate is reduced, and you are surprised how much you miss if you only use standard colonoscopy. So I think these are truly disruptive technologies which might alter the way how we will do colonoscopy in the future, because it allows us to better identify adenomas as well as serrated lesions, and we will see in the future whether the 3 optics or the balloon might play a bigger role. I think the 3 optics are more elegant because also the navigation is eased. You might ask, what is the value of just seeing better, high definition colonoscopy or virtual chroma endoscopy? And we all love these flat screens, not only my kids, it's also for medicine. If you use it once, the details are much better seen. But if you look on a meta-analysis, your additional yield to detect adenomas is only, or at least, 3.8%. The next question is, if you would use virtual chroma endoscopy, just switching a button and then having iScan, NBI, FICE, or whatever you use, how good are you to predict the histology of a polyp? And there's the first study having a direct comparison between iScan and NBI for characterization of small polyps. And this is the technique. You just have this high definition image, and then you use post-processing filters like here iScan or the NBI filtering. And then your sensitivity to identify adenomas is with NBI almost 90%, and with iScan above 90%. So we are getting more accurate because we detect more polyps now by reading the surface to predict what is the final histology, and might be able to target our biopsies better in the future and to select the right target. But what is the true role of real chroma endoscopy? I'd like to show you that in a short video, because that might say more words than a study. Here's the colorectal cancer. Can't see it? Have a look. There's the cancer. Okay, let's switch on some virtual chroma endoscopy, and you might see some very subtle changes. And if you are very well trained, you might think that there could be something behind, but now just use real chroma-endoscopy, and everybody in the room will see that there's something wrong. And these are the very famous depressed early types of colorectal cancer with a size of 5 millimeters. In 50%, you have already submucosal invasion. So for patients at elevated risk, first-degree relatives having cancer, I think chroma-endoscopy still plays a role. And this was shown in this study at GUT, where pan-chroma-endoscopy was performed, and you see patients with at least one adenoma were identified in 46% using chroma-endoscopy, and with white light only in 36%. The real value of chroma-endoscopy is also seen in IBD patients. As you know, they have a much higher risk to develop colitis-associated dysplasia, inflammation-triggered cancer compared to the normal population. And we started in 2003 with chroma-endoscopy in those patients, and you see that this looks like inflammation, but after chroma-endoscopy, you unmask lesions, you can really see the borders of the lesion. And today we can combine high-definition endoscopy with chroma-endoscopy, and this is high-grade dysplasia, and this is an early cancer. And I'd like to show you the technique because it's very simple. This is a young lady. She's 36 years old, but she had ulcerative colitis until she was 14. Now, if you look in her rectum, you see a bit fragile mucosa, but it looks almost completely normal. She might have even mucosal healing in that area. And now you apply that dye in an untargeted fashion. You just stain the whole area or the segment. And now you get two new information. One information is that you can read the surface detail very nicely by using now zoom endoscopy. And then you can identify single colonic crypts. But what is even more important, you can unmask lesions which are not identifiable with your naked eye with white light endoscopy. And here you see the lesion. It's completely flat. It's a so-called 2B lesion. But now after chroma-endoscopy, you see that this structure is different to the normal mucosa. So you can target your biopsy, and you can even do a targeted endoscopic resection. So chroma-endoscopy is of great help in patients with inflammatory bowel disease if they have pancolitis. And there's now meta-analysis done in 2011, and you see you only have to dye or stain 14 patients, then you will have at least one more with one colitis-associated dysplasia or intraepithelial neoplasia. And now in the ECHO guideline, it's now recommended to use chroma-endoscopy in those patients. If you ask me what is the best technology to predict final histology, you see there are different techniques, NBI, iScan, FICE, autofluorescence, and endomicroscopy. At the end, endomicroscopy wins. It's the most sensitive one, but maybe too expensive to use. So my advice is to use virtual chroma-endoscopy and standard colonoscopy and real chroma-endoscopy in patients with elevated colon cancer risk. The last thing is about endomicroscopy. You might get bored because you think, why do we need a microscope into the body of the patient? If you apply a microscope, you can see cellular detail, which is quite interesting, and I have here a short video clip about that technique. You see there's a laser microscope in the distal end of the endoscope, and this brings blue laser light to the mucosa, and here I use a little specimen, which is fluorescent, and now we do a magnification here, and these are single wool fibers, and they are now seen 1,000 times magnified. So you really can see the single fibers. If you take now the microscope into the body of the patient, you only have a field of view of half a square millimeter. However, now you can see colonic crypts, you can see vessel architecture, and even single cellular detail. These are the images. They are grayscale images, but these are goblet cells. This is a crypt. This is conventional histology, and this is colon cancer. So here we do not predict histology, we really can see histology. And the combination could be cancer screening in IBD, and they get a lot of referrals when one biopsy was cancer dysplasia and nobody can find it. And then chroma-endoscopy can be used to identify areas of interest, and then endomicroscopy is able to see whether a real biopsy is needed or not. So you end up with average 4 biopsies per patient, For sure, the colonoscopy takes you 10 more minutes, but I think in those selected population, this might be very useful. Something which is very new for endomicroscopy and also for gastroenterology is that we can see the enteric nervous system. As you know, irritable bowel syndrome is so common, but we do not understand the pathology behind. And we now used a probe endomicroscope to put after polyp resection or after mucosal resection into the submucosal layer, and we stained that submucosal layer with a bit of a contrast agent which is called racroflavin. And then all these white spots, these are the enteric fibers or the enteric nervous system, which can be identified very clearly. And now more research can be done to understand that value and the amount of enteric nervous system in patients with irritable bowel syndrome as well as in IBD patients. And lastly, but that's something into the future, but it's real now for the first time done in human beings, is molecular imaging. As you know, if you give cetuximab or adalimumab in patients with Crohn's disease, you know that the response rate is about 50, maybe 60%. It would be very nice to have a biological marker to see whether patients will respond or not. So what we did, we used adalimumab and we labeled it with fluorescein so that we could see it with the endomicroscope. Then we applied that adalimumab to the normal colonic mucosa or the inflamed colonic mucosa, and we could identify then the antibody in the mucosa. And then we looked whether patients express the membranous TNF-alpha receptor positive or not, and we then collected whether patients had a lot of these receptors, which is the target of adalimumab, or just very few of those receptors. And then we treated the patient afterwards with injection therapy, with Humira or adalimumab, and you see those which had a high amount of the receptor responded very well. As you see, the CDIE score drops down, and those which didn't express the receptor did not respond to that therapy. And this will be a Nature Medicine publication coming up very soon, because it's for the first time that we can do, as endoscopists, molecular imaging. So I'd like to conclude, overall, I think there are a lot of advances in colonoscopy, better adenoma detection rate with a lot of new endoscopes. We can better characterize lesions with simple techniques like virtual chroma endoscopy or then real chroma endoscopy, and even functional imaging and molecular imaging can be done then using endomicroscopy. And I'd like to thank you again for your kind invitation. Thank you.
Well, Dr. Klesslich, thank you very much indeed. It was a very impressive talk, very impressive images. Thank you very much indeed. Any question from the audience? Anything? Anybody who would like to say something? Yes, may I?
I'd like to know about the size of missed polyps.
The size of missed polyps, yes.
It's a very good question. So the size of missed lesions is often flat and small polyps. So they might be not as important as if we miss them. However, we miss a lot on the right side, and even there the small polyps and flat lesions can be serrated, and then they might trigger earlier to colon cancer. So you're completely right, there's small polyps, and we have to learn in the future which polyps are important and which not. But first we have to see them before we can make that decision.
Indeed, there's a lot of discussion whether the interval of 10 years has to be shortened if there is a normal colonoscopy, and that's because of what Dr. Karmanolis asked.
So we asked all the German gastroenterologists who is sticking to the guidelines or who is doing the endoscopy earlier, shortening, and 78% are doing it earlier.
78% are doing it.
So they seem not to believe themselves. Or the guidelines.
The problem is, I just want to ask you, because I have seen some data from Germany as well, that the screening colonoscopy in the general population is not as yet so popular. I mean, the acceptance rate is low, even in Germany.
Correct. It's only 19%, so we'd like to change it because we see now data that it's efficient. Now people will get a letter if they're becoming 55. Now you are qualified to come to colonoscopy, and we believe that this will increase the acceptance rate about 4-fold. Okay. The problem is that we also do not have enough gastroenterologists, if they all will come. And I think in the future we might get serological markers where you get a blood test and then see whether you have an adenoma or not, but that's a bit speculation in the future.
Okay. Any other question from the audience? Yes, Dr. Manzaris, and then Dr. Panos, and then Dr.
Well,
Paspatis.
thank you very much for this excellent. Now, a simple question regarding the application of this new exciting technology apart from molecular imaging. What about studying the interaction between microbiota and the immune system, especially in Crohn's disease? You know, there are less defenses there, more microbes are attached to the epithelium, more invasion in the epithelium. Could you use this, actually, technology in order to see live streaming what is happening in the mucosa?
Yes, I could show you some images because that's truly possible. You can identify bacteria with endomicroscopy, and you even can see that these bacteria are more often in the lamina propria, what we call intramucosal bacteria. And this has to do that there's a misfunction of cell shedding. So the cell is shedding in Crohn's patients, but the little gap which occurs is not closed. So then bacteria can travel into the mucosa, and this can be seen with endomicroscopy. And there's a lot of research now done about the microbiome and the interplay between the mucosa and the bacteria inside the tissue. And I think this will help us to much better understand the pathogenesis of IBD patients.
Dr. Panos?
My question is to do with looking behind folds.
Yes.
Have you had any experience of the endocuff, the attachment at the tip of the endoscope?
Yeah. I also had some experience with the endocuff. I felt that the balloon system is better because it can widening the colonic folds a little bit better than the endocuff. However, we have to see the study results of endocuff, whether this is in the same efficiency as the other techniques. But there I'm a bit more skeptical, but we will see.
And the last question from Dr. Paspatis.
High definition colonoscopy with white light is the usual practice for screening colonoscopies in middle average patients.
Yes.
Do you have the feeling, as an expert, that we are going to move in more sophisticated imaging techniques in the future for screening colonoscopies?
That's a good question. I think that's already a huge step to have high definition colonoscopy now in all screening colonoscopy, which is not true in all cases. So I think this will help us to come over the threshold of 20% adenoma detection rate, because all the studies are showing if you use high definition, you're already between 25 to 40%. So I think if you do a high definition colonoscopy, that's perfectly good. But if you would like to do something in addition, you can use virtual chroma endoscopy or real chroma endoscopy.